This presentation is on sex and sports, caring for the female athlete. I was assigned to do the talk on ACL injuries. My name is Mary Lloyd Ireland. This symposium was presented at the American Academy of Orthopaedic Surgeons in Orlando. It was sponsored by the Women's Health Issues Advisory Board, and particularly headed and giving credit to Cordelia Carter and Liz Matzkin, who really got us all together for this. I've been in practice for 30 years, and after appreciating non-contact ACL injuries have higher rates in basketball, what progress have we really made? Before professional basketball athletes were allowed to participate in the Olympics, we did have comparisons of males and females of the elite pick of our basketball coaches for men and women. And it was noted that there was a significant greater rate of ACL injuries in females compared to males. And in fact, knee arthroscopy and other knee injuries in females compared to males. These were non-contact injuries. This was reported and written up by Cindy Wall and me, presented at the American College of Sports Medicine in 1989. So pre-Dream Team 1988, where were no pros, what we found looking at the athletes who were invited to come try out for the Olympic teams are these numbers. So there were 80 males and 64 females. 20 or 18% had undergone surgery, and the females were a significantly greater number that underwent surgery, 31% compared to 7.5%. ACL reconstructions in this group, 8 females, 2 males. So a significant difference in the numbers of ACL injuries at the elite level, but even at that time, reconstructions were being done, and these athletes returned from a basketball injury to continue to compete at this elite level, Olympic level. When we look at these ACL injuries, epidemiology tells us that female-male rates continue to remain higher. Basketball and team handball in particular. The references are below, and I would suggest to you that you look at these references for more information. The NCAA kept records for 15 years, and these are summarized here. The top is basketball, comparing women to men. You can see where there are spikes, where there were increased rates at certain times, like in the first year, and then in here in the mid-90s. But overall, the rate has remained significantly different, 3.38 times greater ACL injury rate in women compared to men. And also soccer, again, there can be some peaks and valleys there, but in soccer it was 2.75 men to women injury rate. These sex differences, the incidence remains 2 to 8 times greater in ACL tears in females in basketball, team handball, netball, alpine skiing, and soccer. The risk factors include not modifiable, such as anatomic and structural or hormonal, and modifiable. That would be neuromuscular, biomechanical. In the expert think tanks that I've been involved in, the agreement is that the modifiable factors are the most important. So what we emphasize are modifiable factors for return to play and also for prevention programs. In other words, how to land safely in a more flexed hip and knee position, both feet. Anatomic differences in the knee that really are not sex related include the size of the notch, the shape of the notch, the tibial slope on sagittal measurements. Normal is 10 degrees posterior slope. A greater posterior slope is at risk for ACL injury. The size of the ligament, the femoral condyle size and shape. So these can certainly be individual or race dependent, but they're not sex dependent in basic science studies. The notch size and shape, there are no sex differences. However, a smaller notch houses a smaller ligament. Smaller ratios, if you take the distal femur to the notch ratios, which normalizes it, still no sex differences. Smaller notches have smaller ligaments, and the question is that smaller ligament at risk for tearing? This shows a congenitally absent anterior cruciate ligament, and you can see here where no notch has formed at all. This is what the normal anterior cruciate ligament looks like and the normal notch. X-rays can be variable. There can be different shapes to notches. If you see this, this is more like a U shape, probably houses a huge ligament. More of an A shape here. So there can be different shapes, but the shapes are not sex dependent either. With our study, we looked at 108 ACL injuries, equal number men and women, 186 intact ACLs, looked at the width of the femur and the notch, the ratio, notch width ratio, and the different shapes. Our findings were no sex differences. Smaller notch equals increased risk of ACL injury. What about the bony morphology? Certainly the female has hyperextension of the knee, a physiologic pivot glide when we examine her, a lot more often than boys do. So can there be a difference in the female knee as far as shape and size of the femoral condyles? There are some studies that analyze the variation of the femur using sex-specific atlases. I think this will be something that we'll learn more about with advanced imaging, comparing families, comparing race, comparing sex. The female knee in this study had a less wide femoral condyle and significant differences between the medial more than the lateral femoral condyle. What about the tibial plateau geometry? More studies have been coming out recently about the slope of the tibia, but also about the tibial depth. Again, no sex differences, but there can be individual differences. The tibial plateau risk model has been written about by Hashimi in these two publications that are shown. This includes the medial and lateral tibial slope as well as the medial tibial depth. And if you look at the odds ratio, 1 millimeter reduced medial tibial plateau and 1 degree increased slope, there were some differences. These are the measurements that are made, and I think we'll see more and more work done on the morphology of the femur and also the depth and size of the tibial plateaus. MRI scans are needed to do these measurements, and you'll see more about the bony morphology. What about intrinsic differences? Hormonal joint laxity. Data are insufficient to make any conclusive statement regarding the menstrual cycle of knee laxity and on the rate of ACL injuries in females. This is from Journal of American Academy of Orthopaedic Surgeons, Yellow Journal, Sutton et al. From 2013. So do not change a female's level of participation or game participation based on her menstrual cycle. Some studies have been done by the history of the menstrual cycle, but truly they need to be done by urine analysis or saliva analysis of what's really going on with the hormones levels during the cycle. We really don't see any other musculoskeletal problems occur at different times during the cycle, so why would there be increased risk of ACL injuries during certain phases of the cycle? What about genetics? The COL5A1 gene is associated with increased risk of ACL tears in females. This is a gene that encodes alpha-1 chain of type 1 collagen in ACL tears and type 5 collagen in acute Achilles tendon tears. This is from work in South Africa with a reference noted below, published in the American Journal of Sports Medicine by Posthumus and other workers in South Africa. More to come on this. The question becomes, what do you do with that information if you know there is genetic predisposition to certain injuries? Hypermobility or excessive joint laxity associated with increased risk incidence of musculoskeletal injury. The jury is still out on this. There have been reports yes and reports no. Extrinsic factors, also the kinematics, valgus collapse and increased knee abduction moment, has been studied and published extensively by Tim Hewitt and his co-workers. This study was 205 female athletes who had 9 ACL tears. The greater abduction moment predicted ACL injury at a statistically significant level, p less than 0.001. In observing simple tasks such as doing mini squats, the male is on the left, the female is on the right. These are uninjured individuals. We notice certain differences in trunk and hip and subsequently knee position. If you look at the male from the front on the left, his pelvis is level, hip is straight without rotation, knee is straight, the tibia is in neutral, foot flat, and pelvis is in neutral. Looking at the female on the right, you can certainly tell a big difference. Again, no injuries, normal individuals. She has a Trendelenburg contralateral drop. Hip is internally rotated. She's just trying to stand on one foot, and her strategy is to be able to do that with her hip internally rotated on the right. Knee goes into valgus. Tibia is in external rotation, foot is pronated, and if you look on the right-hand side from the side view, she has hyperlordosis, her body is forward, and her pelvis is anteriorly tilted. Look at the male on the left, where his back is in neutral, relatively flat, and his body is more upright, and his pelvis is not tilted anteriorly or posteriorly, it's in neutral. So these differences in normal individuals, if you have somebody that has a injury, it could even be an ankle injury or a back injury, maybe this pushes them over the edge to not even be able to maintain this position as these normals. Mechanism injury, there's no sex difference in non-contact mechanism. Basically, it's a weight-bearing pivot shift that occurs. The real question is, when does the injury occur? When do you tear your ACL? We've got 4 different times here, and then these are the stick figures of that upper drawing. So this individual grabbed a rebound. Look at her trunk body weight when she comes forward like this. The knee isn't as ugly as it is here, so she probably tears it somewhere between here and here. And the shifting that they feel is as the ACL tears and then goes back into place. The tibia is reduced when they do the knee to chest position, the heart attack of the knee, if you will. The player on the right receives the ball, lands, tears her ACL. If you look at her landing pattern, most of her weight is on her right side, her body's forward. She catches it while she's in the paint. She's out of her cone of stability. In other words, her knee and foot are not under the axis of her body. She's thinking about a lot of different things, keeping the ball from going out of bounds, grabbing it, putting it back up. And again, this is the heart attack of the knee. She tears her ACL, lands awkwardly. You can see it buckle. If you think about what's happening, it's like VROOM, valgus, rotation, out of control movement. It takes 70 milliseconds to tear the ACL. So oftentimes these are in the paint, balls overthrown, thinking about doing different things, come down on one side, more upright, trunks out of position, more forward, hip internally rotates, foot hits the ground, and something's got to go, and unfortunately it's the ACL in that rotation mechanism or that weight-bearing pivot shift coming down from a jump. How do we teach athletes to land in a safe position? Well, by observing the way not to land, we can back it up and figure out what the best joint positions are. And in the right joint positions, the muscles can act better as well. So if you think about muscles being agonist-antagonist, think about muscle activity and the degree of flexion of particularly the hip and the knee. The position of no return shown diagrammatically up top, and then on the right, the body is flexed forward, trunk rotated to the opposite side. The hip is in adduction and internal rotation, and then again to remain an upright position. What happens is the knee goes into valgus. It's relatively extended, less flexed. And in basketball, at least, the tibia externally rotates, the foot is pronated, and something happens and the ACL tears in that very quick 70 millisecond rotation that occurs. So kind of the bad muscles for an ACL injuries are hip flexors, the quadriceps, dorsiflexors of the foot, and peroneals. Now if we talk about the position of safety, that's more in a get down, flexed hip, flexed knee position. The back and trunk are normal, not forward, normal lordosis. The hips are flexed, neutral abduction, adduction, neutral rotation. Knees are flexed. This facilitates the muscles of your hip extensors, abductors, gluteal musculature, as well as your hamstrings to protect the ACL, preventing the tibia from coming forward. The tibial rotation is neutral, both feet landing in control and balanced, making the calf muscles of the plantar flexors, gastroc, posterior tibialis, again be more protective in sticking the landing safely. Core stability, it's never too early to start. You can climb trees, you can do hula hoop, you can do whatever to climb and land, but learn how to land early, never too early to start. In studies of prevention and post-ACL reconstruction rehab programs, there are no sex differences. There have been multiple think tanks headed by Edie Hunter-Griffin. This is one of them that was reported 10 years ago in the American Journal of Sports Medicine. This small textbook is a good one to have on hand for educating patients, parents, coaches, and others. Understanding and preventing non-contact ACL injuries. This was the Hunt Valley meeting number 2 of a think tank. ACL reconstructions, if you look at those sitting for the American Board of Orthopaedic Surgeons test, The most common age ACL reconstructions are performed in the United States is 15 years for females and 18 years for males. So that at-risk female is age 15. She's already gone through her growth phase. She might be newly recruited for basketball, but the 15-year-old female, highest ACL reconstruction rate. In my practice, Kentucky Sports Medicine, we looked at sex differences in basketball athletes, and the females were younger than the males by 5 years. So it could be that the females, as they got into their 20s, weren't as active in sports or quit playing basketball, and the males perhaps kept on playing basketball or doing high-risk stop-cut change direction sports, but the females were younger by 5 years than the males of the ACL reconstructions I performed. Looking at a 15-year experience, the rate of revision, re-tears, not statistically different. This is a retrospective study. In the females, 5% revision rate, males, 4% revision rate. So these are in ACL previous reconstructed that came back and had revisions done. In basketball, ACL subsequent surgeries, the reconstructed side, a 3% failure rate, the opposite side, a 6% failure rate. So 2 times more likely to tear the uninjured or normal knee compared to the reconstructed knee. These are the total ACL surgeries. So I did a lot more ACL surgeries in males, multiple surgeries. There were more equalization of that, but not statistically significant. Return to play activity level based on the MOON study. This is a soccer study. Average age was 24. The follow-up at 7 years, 30% of this group were still playing soccer. Females were more likely to have further ACL surgery, 20% in females versus 5.5% in males, p-value equal to 0.03. Statistically significant also were that older athletes and females were less likely to return to play, p-value equals 0.37. This is from the MOON group, published in American Journal of Sports Medicine, 2012. Outcomes. Do outcomes differ by sex? This is a meta-analysis of 13 studies. There are no sex differences in graft failure risk, 8 studies, contralateral ACL rupture risk, 3 studies, laxity post-op clinical exam, 6 studies, no difference evidence of a clinically important in patient-recorded outcomes according to sex. However, more high-quality studies are needed. What about the development of osteoarthritis? In a Swedish ACL registry, follow-up 12 years. This is of 84 female soccer players who had had ACL injuries. 42% symptomatic knee osteoarthritis. 75% symptoms affected their quality of life. And there was no difference if the patient underwent ACL reconstruction compared to those who had not. That's a pretty sobering statement. It really motivates us to follow our patients, follow them long term, see them at 10 and 20 years post ACL reconstruction, and follow them with radiographs standing. Development of osteoarthritis, we need longer-term registry. Follow-up is needed. Some of the national groups, such as MOON and MARS, are great. However, in our own big practices, universities, we should also follow these patients and find out what their rate of osteoarthritis is. Unfortunately, it's probably higher than we think. This is an individual who 2 years after her ACL reconstruction, she didn't have any X-ray abnormalities at the time of the injury, and now she has tricompartment osteoarthritis. Previously, I'd been seeing her for patellofemoral arthritis on the opposite side, and you can see here where now she has significant tricompartment osteoarthritis, 38 years old. Is decision-making different for ACL management based on sex? No, it should not be different by treatment by healthcare professionals. The decision to reconstruct the ACL and graft choice should not be different, since athletes, whether male or female, have the same desire to compete and win. So no sex difference in decision making. This is a sad article in the New York Times about this high school soccer player who had had multiple ACL reconstructions, 2 or 3 on both knees. And this was her mindset. After surgeries, she always wanted to rehab hard, get back on the field, compete fiercely. And I think this hope not to be re-injured, or hope not to be injured, is one that if she doesn't get over that, she will be re-injured. So there certainly is a fear of re-injury, and maybe females think that a little bit more. But if you think you're going to be re-injured, you probably will injure something. So this is something that we need to work more with both male and female athletes about verbalizing fear of re-injury, because they're going on that same playing field and a non-contact mechanism is most common. Get them ready physically by gait analysis, by strength measurement, and also by mental awareness and making sure that they're ready to go back, not fearful of re-injury.
I can take the pain and I can take the hurt, because I'm so competitive, and I wouldn't care. I would tear my ACL, just to win a national championship. That's all I want.
This University of Tennessee basketball athlete, that's what most of these athletes voice, whether they're playing middle school, high school, college, females or males. Oftentimes the females don't have the opportunities in professional sports, but they certainly will give everything for championships and for their team, their coaches, and their families. Respect that and treat them fairly and equal. At the Academy in Orlando was an exhibit, Sex-Based Considerations in Caring for Common Sports Injuries, which I did the ACL part. Again, this was sponsored by the Women's Health Issues Advisory Board. Members are shown here. Laura Gehrig is the president. Doctors Baker, Carter, Hilden, Johnson, and Matskin participated in this and have been very dedicated to contributing to women's health issues and serving on the board. I was privileged to be a past member of the board, WEHAB, when I represented the Ruth Jackson Orthopaedic Society. This summarizes that exhibit that was well received. Thank you for your attention. Keep on treating ACL injuries similarly, whether they happen to be males or females.